Start my slides are like back. Start video. Slide share. Slide share का अपने desktop पर नहीं लगे ना?
I'll just check my slides sharing once.
Yeah.
Is my are my slides visible, sir?
Yes.
Okay.
Just like video.
These are Lipika ma'am's slide. I'll be sharing it from my screen.
Slides.
Yes, sir, it's okay. Just
No, we are not able to share the slides, sir.
screen sharing is okay.
Ashish sir, if I may help you.
Yeah.
What you can do is on your PowerPoint, you put it on slideshow mode. Okay.
Okay.
In the PowerPoint presentation, you put that class icon. You press on that. Your screen will become a slideshow. Now.
But I have to initially minimize this.
Matlab, yes, minimize this Zoom screen.
Okay. It is not getting minimized.
Okay. Okay, sir. How about this? You press Alt button on your keypad with tab. When you do that, Alt and tab together. Alt and tab.
Okay.
When you press Alt and tab, all your windows will be shown.
Now we have gone back to Digi Feed.
Sir, Alt and tab you'll get all the tabs which are open on your screen. Is that coming or no?
No. I will try again. Alt and tab press together.
No, just Alt and then उसके बाद आप tab दबाएंगे सर आपके सारे tabs जो खुले हैं वो दिखेंगे. वो आ रहा है क्या?
Or Kirtika, otherwise you can take the slides of Ashish and you can show it.
Yes, ma'am. I also feel that. Yeah, it's coming, ma'am. Mitral Regurgitation is coming. Other topics.
Okay. Just 1 minute.
Narendra sir's screen is
just 1 minute.
For viewers, it will take hardly 2 minutes to start the session. Today we have almost what I can say, 4 movies in one ticket, like that. So 2 speakers today, they will taught on all OBGY problems of heart and related to that. Please be patiently wait. The show will start immediately. I want to share this thing that today's topics are obstetrician in distress, anesthesiologist in stress, will be presented by Dr. Ashish Mali sir. He is associate professor at Topiwala Nair and BOL Nair Hospital. Next topic will be a tale of regurgitant heart lesions. It will be a parturient with mitral regurgitation for seizure, and this one will be presented by Dr. Narendra Kumar. He is a assistant professor at Nair Hospital. The third one will be again one regurgitant heart patient, and that will be parturient with aortic regurgitation for seizure. It will be presented by Dr. Kritika Yadav. She is a senior resident at Nair Hospital. And last, ma'am will be take, and that will be key points for the practice of obstetric anesthesia. She will deliver us take home message for OBGY cases in our private practice. So tighten your seat belts. We will soon start the session. Are you ready, sir? Ashish, sir?
Minutes. 2 minutes.
Stop sharing, please.
Yeah. Okay. Depend. This echo is coming from Ashish Mali sir's voice.
Yeah.
Okay, sir.
I think he's using 2 devices.
Okay. Ashish sir,
Yes, sir.
you are using 2 devices, so echo is coming.
No, sir. Single one only.
It's okay. Now it's coming. Okay.
Okay, sir.
So, hello.
Are my slides visible, sir?
Yeah. It's clearly. Should I introduce for 2 minutes? Then you start the screen sharing.
Yes, sir.
Yeah. This is our case meet on the eve of ISF flame, and our flame is coming on Saturday evening. Our plannings and all things are going on from ISA City Branch Nanded, and on this eve we are presenting case meet 38 on this platinum jubilee years. This one today's topic is obstetric distress, anesthetist in stress, that we all know, and our honorable ma'am Dr. Lipika is presenting with her all team this ops topic. Previously we learned a lot from him her about cath labs. Today's topics, I already mentioned about 4 speakers in one show, and the first one will be stalwart Dr. Ashish sir. He is an associate professor in Department of Anesthesia in the TNMC and UL Nair Hospital. And then presentation of Dr. Narendra Kumar. He is assistant professor at same hospital, Nair Hospital. And then Kritika Yadav. She is a senior resident. She will speak on regurgitation of hearts. And then after keynotes from Lipika ma'am. So on Platinum Jubilee celebration of our ISA National plus 25 years of Silver Jubilee years of our ISA City Brand Nanded, we are doing this case meets. Thank you all. Ashish sir, you can start.
Sachin, I would like to mention that Dr. Ashish has been planning to take up the obstetrics fellowship course shortly, and
Okay.
he's interested in obstetric anesthesia. He has recently come back with the experience from Hyderabad, so he can enlighten us more about all these points.
Yes. Ashish sir is our senior from Nair Hospital and a very humble person.
Yeah. Can we start, sir?
Yes, sir. Yes, sir. Please.
Yeah. Am I audible to all?
Yes, yes.
Yeah.
You are audible.
Yeah. You can just start. Today's topic for discussion today is obstetrician in distress and anesthesiologist in stress. So basically in this topic, we are looking at how the distress of the obstetrician causes increase in the grades of anesthesiologist because they are already stressed by the anesthesia factors. In addition, the obstetrician gives us a lot of distress. We'll continue with the slides. The first slide shows what are actually the obstetrician stress. It is not an obstetric stress, it is an obstetrician stress, which ultimately causes the stress to the anesthetist. There are problems like erratic routines, hospital setups, small nursing
Sir,
homes give a lot
above logo is there, na? One logo on above home. There is play the slides. If you, yes, above the home. File home insert draw is above. In brown area above.
brown area. Where's the new?
No. On left side, sir.
Achha.
Above that you just above insert, insert. Above that.
Okay, yeah. Click
You
on
just
that.
click it. Start from beginning. It will be start. Yes.
Yeah. This is better, sir.
Thank you. Yes.
Yeah. So today's topic for discussion is obstetrician distress and anesthesiology in stress. We are just going to mention what ultimately causes the stress to the anesthetist. Coming to the first slide, what exactly are the stress for the obstetrician? That is erratic routines of there regarding the food, sleep, and the stress. Regarding the hospital setups, because small nursing homes gives them a lot of stress. They are also always concerned regarding the two lives. First one is the baby and second is the mother. One more important, whether they are able to reach in time when the patient is in labor. Currently, the most important concerns are regarding the medico-legal issues. Another one is blood and bleeding of the patient. One of them, addition, is finding a good pediatrician, monetary dynamics, and the most important is finding a good anesthetist who can deliver the baby and the mother well. Now we are coming to the actual acute emergencies which are there for the obstetrician, which ultimately cause stress to the anesthetist. Here you can see that the anesthetist only stress is remaining written only one time, because every time this goes on increasing, the stress of the anesthetist increases. The most important of them are the fetal bradycardia and the cord prolapse. Here in each of the slides, I will be just discussing what are the important concerns for the anesthetist in all of these conditions. The rest of the discussion will be doing by the further speakers. In case of fetal bradycardia and cord prolapse, important in this patient is maintaining the glucose, the blood pressure, and the oxygenation of the patient. In case of dire emergency, general anesthesia should be given to the patient, taking into consideration thiopental and scoline. Another important factor in this is meconium stained lacquer, in which consideration has to be taken with the pediatrician and the gynecologist, looking whether a rapid spinal can be given or general anesthesia should be given. In case of PIH, that is pregnancy-induced hypertension, the concerns are whether it is a gestational hypertension, whether it is a chronic hypertension, whether it is a pre-eclampsia, whether it is an impending eclampsia, and whether it is an eclampsia. The concerns for the anesthetist which cause stress to him are something like the urine output, whether it is a HELP syndrome, is the patient is in sepsis, magnesium sulfate regimes which are followed by the gynecologist, whether the patient has some DIC problems or coagulation problems. One more addition to this is important, whether the patient is taking which type of medications. The next point which comes in line is hemorrhage, whether it is an antepartum hemorrhage or the postpartum hemorrhage. In both of them, the very important cause is rapid and acute loss of the blood and massive transfusion. In case of ruptured uterus and ruptured ectopic, right from the induction, it is very, very important regarding the BP, how the induction is going to be done, invasive monitoring, and post-operative care. In case of embolism, even if the patient is given spinal, it has to be converted to GA with oxygenation and the post-op shifting of the patient to the ICU. Next, in addition to this, the initial slide showed what are the acute problems. Now, these are showing the associated comorbid problems which causes stress to the obstetrician. Now you can see the anesthetist is slowly getting stressed up. Hence, the stress is written 2 times. In this case, we have been seeing the most important problem of pregnancy is anemia in pregnancy. Already the patient is in delusional state with hypercoagulable state. In addition, the problems will be like thalassemia, megaloblastic anemia, and sickle cell anemia. In case of heart disease, care has to be taken whether it is a stenotic lesion or a regurgitated lesion, whether the patient has a dilated cardiomyopathy. Intraoperative, the patient may have CCF, and even the post-op, the patient may go in CCF. Also, concern has to be taken regarding any BMD was done previous or the valve was replaced anytime. In case of kidney diseases, concern of anesthesia will be the hemoglobin, which is always on the lower side, potassium, which may be on the higher side, whether the patient is having any urine output, what is the creatinine status of the patient, whether the patient is receiving any dialysis, and whether the patient is on any other medications. Considering now the musculoskeletal systems, what are the main concerns are something which we call as the kyphoscoliosis. In this, there is problem regarding regional anesthesia because it is very, very difficult to locate the space. Hence, sonography may be useful in such cases. Also, giving GA will be very, very dangerous because the lung is already in the restrictive phases. Other important problems are something like myasthenia gravis, which may impede telling of the hyperthermia crisis. Also, rheumatoid arthritis is one of the problems which causes airway problems as well as the regional problems. In all of these cases, a cart for difficult intubation has to be kept ready. We come to the next condition, what we call as the bronchial asthma. In this, concerns for the anesthetist is the patient may already be on steroids. There may be edema of the airways. The patient may be in the status of spasm. And last but not the least, the patient may go in edema. In elderly and precocious patients as well as the IUGR, they may be an IVF conception. Hence, we cannot refuse a chance of patient being hypertensive. Also, other problems like hypothyroid may be already present for the patient. In case of multiple gestations, things like decreasing the dose of spinal as well as PPH has to be considered. Before this, the 2 slides were only concerned regarding to the obstetrician which were giving stress to the anesthetist. Now, actually, the business comes when the anesthetist is stressed by his own problems, that is the anesthesia concern. Hence, now the stress is increased by 3 times, that is stress, stress, and stress. First of all, the consent. Second is the blood. Third is optimization of the patient, time availability for optimization, surgical skills, availability of the pediatrician, and last but not the least, ICU and NICU facilities. Coming to the first, that is whether availability of the consent, that is whether the relatives were available or not. Are they blood relatives? Need for an alternative consent. Like if the patient's relative is not available or the patient has come in unconscious patient, then the administrative has to intervene in this. The most important part in this part is explanation of the risk involved in obstetrics and anesthesia, that is regarding PPH, blood pressure, ICU, heart disease, or asthmatic problems. Last but not the least is the denial of the consent. Sometimes the patient will not give consent for giving regional instead of GA. In this case, the pros and cons have to be explained. And even if the patient doesn't give a consent, a negative consent has to be taken and the patient has to be proceed with the procedure. Next important is regarding reservation of the blood and blood products. In this, concerns are availability of the blood in the hospital, how much tagline it is time lag it is going to take for availability, blood groups and its components available in full swing. Rare blood groups like Bombay blood group always give problems. Jehovah's Witness are a chronic problems. Even consent for the blood products have to be taken regarding reaction. And last but not the least, transfusion reaction trial has to be considered. In case of the next point, which is unoptimized patients, many a times the patients are not nil by mouth. They may have just have clear fluids or full meal before the section, and the obstetrician tells us to give the anesthesia. In this case, more concern for the anesthetist is because the progesterone causes decreases in the sphincter tone of the esophagus, and also diaphragm is on the higher side because the gravid uterus presses on the stomach. Other concerns regarding unoptimized patients are like coagulation issues, electrolyte disturbances, and unavailability or non-availability of the investigations. Or sometimes a minimal of CBC will be available. In this case, we have to proceed with the investigation. The bare minimum what we can do, we can just draw a sample of blood and send for the investigations, look at the clinical conditions of the patient and proceed for the section, because important are the two lives, that is the mother and the baby. Also, concern will be undiagnosed comorbid things, DIC and sepsis. After optimization, is the anesthetist have adequate time for optimization? This is because the time of optimization is very, very less. It starts from the admission counter to the patient coming to the operation theater. In case the patient is having spasm, in case the patient is having CCF, or the patient is hypovolemic, this all have to be considered and optimized by giving astaline or blood or whatever is required. Also, unoptimization or decreased optimization of the patient in the pre-operative period causes increased stay in the post-operative period and ICU for the patient. This is not actually directly related, that is the surgical skill. This is actually not related to the anesthetist, but it actually affects the anesthetist, because if the surgeon doesn't have good surgical skill, he can just remove the S and he can really kill the patient. So what is important in the patient is how much time should ideally be there. So some 3 to 4 minutes should be ideally present in case of GA for the baby delivery, and about 7 to 8 minutes in case of regional. The case doesn't end here, because the surgeon should be able to also manage the PPH, that is the hemorrhage of the patient, and also he should be saving the ureter and the peri-uterine areas. Here the role of the anesthetist changes, that is the availability of the pediatrician. Suddenly we may find that the pediatrician is not available and the anesthetist had been told to do the role of the pediatrician. He doesn't get any incentive, but he has to take care of both, that is the mother as well as baby. So it is very, very challenging job. Last but not the least is, after the patient has been, section has been done, will the patient require ICU in view of PPH, PIH, embolism, any CVTS disorders, and whether the baby will require NICU. With this, I have some concluding note that what actually stresses the anesthetist when he gives GA to such patient, they are the aspiration, airway edema problems, pressure responses to scopies, drugs that includes anesthetic drug as well as the gynecological drugs, end organ concerns, awareness in GA, and fetus himself. When he gives regional anesthesia to such patients, what are the stress factors? That is coagulation problems, finding the anatomical landmarks for giving regional, hypotension, level attained, PDPH, catheter migration, needle and catheter catastrophes, and drug overdose and reactions. So in all, what can be described as the role given to the anesthetist and how can he do the role of the anesthetist in such conditions is first to calm the patient himself, calm the surgeon and the staff, be self-calm to do the things, explain, take the risk. Ultimately, he has to give anesthesia, change the roles if required as a pediatrician, and hope for the best. Thank you.
Thank you, sir. Very nice presentation. And congratulations for your fellowship also. From all our ISA city branch member will congratulate you on these great achievements and your further studies. I think we will start next session. Then last we'll take question and answer sessions. Is it okay, sir?
Yes, sir. I think Nanded is waiting for.
Yes,
I think
sir.
Dr. Kirtika is waiting for.
Yeah. Next is I think Narendra and then Kritika. Whatever I can, we can exchange.
Dr. Kirtika, I think.
Yeah. Please start. No problem.
Yes, sir.
Yes, sir.
Yes, Kritika ma'am, please.
So, Ashish sir, can you exit your share screen? Then I can.
Yeah.
Oh, thank you, sir. Are my slides visible?
Yes.
Okay. Okay. Good evening. My name is Dr. Kirtika Yadav. I'm a senior resident at Nair Hospital. I'd like to continue this interesting discussion on a tale of regurgitant lesions by presenting to you all a case about a parturient with severe aortic regurgitation presented for cesarean section. Okay. So here's the case of a 22-year-old primea gravida at 36 weeks of gestation. She presented to labor room with complaints of pain abdomen since 1 day. She was an unregistered pregnancy. And on asking about her past history, we found out that she was a known case of rheumatic heart disease, diagnosed 4 years back, but she was not on any treatment medically or undergone any surgical correction prior to pregnancy. She had symptoms of breathlessness of NYHA grade 2 to 3 on exertion, and on and off complaints of palpitations and chest discomfort. However, she did not complain of any orthopnea or paroxysmal nocturnal dyspnea in this case. On examination, we found the patient had pallor with pedal edema, which was pitting in type, extending up to her ankles. Vitally, she was afebrile with pulse rate of 102 beats per minute, which was regular in rhythm, high volume and collapsing pulse, with all peripheral pulses felt. This is very characteristic of aortic regurgitation lesion. Her blood pressure showed systolic blood pressure of 130 and diastolic of 62 with a wide pulse pressure, which is again characteristic of aortic regurgitation. Respiratory rate was 16 per minute at rest and saturation was 99% on room air. On systemic examination, her CVS examination revealed a hyperdynamic apex beat palpable in the 6th intercostal space lateral to mid-axillary line. On auscultation, S1, S2 were heard. However, we recognized and identified a diastolic murmur, which was heard best in the aortic region, which is in the right second intercostal space. Her JVP was normal. On respiratory examination, air entry was bilaterally equal with no crepitations. So we ruled out any signs and symptoms of heart failure in this case, which were not present. On neurological and obstetric examination were within normal limits. We evaluated her preoperatively by doing routine biochemical examination, which were within normal limits. Detailed cardiological evaluation showed ECG showing normal sinus rhythm with left axis deviation and left ventricular hypertrophy. 2D echo showed a dilated left ventricle with severe aortic regurgitation, a trileaflet aortic valve with mild MR and trivial TR. Gradient across the valve was 52 by 32 millimeters of mercury, dilated ascending aorta with IVC collapsing, and there was no regional wall motion abnormality or clot present. However, she had good diastolic and systolic function with ejection fraction of 60%. We got her cardiology and cardiovascular surgery clearance done prior to surgery. Room air ABG was also within normal limits, and chest X-ray was not done as she was a pregnant woman. So here's the diagnosis of primea gravida at 36 weeks of gestation with a known case of rheumatic heart disease with severe AR and mild MR with NYHA dyspnea of grade 2 to 3, and she was not in heart failure, and she was posted for elective cesarean section. So now, why are we worried about parturients presenting with cardiovascular diseases? As we know, cardiovascular disease is very commonly complicating pregnancy nowadays and is the leading cause of maternal mortality, especially in the US. The prevalence is not only increasing in the developed countries, but even in India. This can be attributed to the fact that most women, the average maternal age is increased, and the coexisting risk factors such as diabetes, hypertension, and obesity can lead to cardiovascular disease. Pregnancy on its own is associated with significant hemodynamic changes, and that can further aggravate any underlying valvular heart disease in these cases. Signs and symptoms of pregnancy which are physiologically present are similar to that of a cardiovascular disease. So we need to be very vigilant in diagnosing these cases, as we can easily miss them. Patients who are not aware that they have a cardiovascular disease can, because of the hemodynamic stress of pregnancy, can present and be diagnosed for the first time in mid to late pregnancy. So we need to be vigilant in these cases. Physiological increased demand with the fetus, and also the body prepares for the dynamics condition. Increase in plasma volume, the stroke volume increases, which is around 20 to 30%. And this contributes to an increase in cardiac output. Cardiac output increases right from first trimester and reaches a maximum at 32 weeks. And it reaches as high as 30 to 50. Continuous mimetic because of anxiety and pain that can happen. And the cardiac output is maximum in the immediate postpartum period. Now, this is important. We need to know when the cardiac output is high because the patient can postpartum. Aortic regurgitation is well tolerated during pregnancy because of the decrease in systemic vascular resistance, which occurs because of progesterone and the placenta, which is a less resistant circulation. The systemic vascular during pregnancy. So this is what I did prior to this, and this is presented in a graphical representation where we can see that the cardiac output increases during first trimester, reaches its maximum during second and third trimester, but is highest, almost 80% of the baseline value, just immediate postpartum time. And the systemic vascular resistance, as we can see, remains low throughout. At the same time, the plasma volume is high, because of which the preload is constantly maintained. So therefore, aortic regurgitation patients tolerate are asymptomatic usually during pregnancy, unless and until their left ventricular ejection fraction is decreased. Now, what are the normal pregnancy cardiovascular signs and symptoms that we need to know? It is very normal for patients to have easy fatigability, dyspnea, orthopnea, hyperventilation, chest pain because of esophageal reflux disease. Signs such as tachycardia is common in pregnancy with non-specific ST changes are present. Peripheral edema is common. Pseudocardiomegally can occur because the diaphragm is pushed up and that pushes the heart laterally. So we can mistake that for cardiomegaly. It's actually pseudocardiomegaly. Loud S1, S2 is normal to be heard. And there is presence of S3, which is also normal, as pregnancy is a volume overload hyperdynamic condition, as I stated. Flow murmurs are also very common to be present in pregnancy. However, certain signs and symptoms which must alert the anesthesiologist into understanding that this patient might have an underlying heart disease and mandates further cardiological evaluation are symptoms such as severe progressive dyspnea, severe progressive orthopnea, any PND, hemoptysis, exertional dyspnea that the patient complains with effort, any chest pain the patient has, especially related to effort or emotion, or progressive or generalized pitting pedal edema. We need to be aware of these symptoms. Signs such as cyanosis or clubbing, persistent neck vein distension, a loud S4, any diastolic murmur, the systolic murmur grade 3 and above, because less than that flow murmurs can be present, which are normal. Any paradoxical splitting of the heart sound, any sustained dysarrhythmia or pulmonary hypertension signs such as loud P2 and opening snap need to be diagnosed, identified, and that should alert the anesthesiologist into further evaluating the patient for a heart disease. Now, how to approach a patient with aortic regurgitation for elective cesarean section? There are general principles that are to be followed for any pregnant patient with heart disease. We need to understand that the mode of anesthesia depends on the hemodynamic status of the patient and obstetric indication. However, if the patient is asymptomatic, usually the patients tend to do well during section or delivery. But if the patient during pregnancy has NYHA dyspnea class 3 or 4, we should be very vigilant and understand the patient can tolerate the pregnancy the delivery poorly, and can have post-operative ventilatory support or post-operative intensive care requirement. It must be a multidisciplinary approach, so cardiologists and CVTS surgery clearance need to be sought, and the perioperative management advice need to be followed. We need to avoid or treat factors that can worsen heart disease, which I'll be stating later. The patient should be at bed rest with left lateral position to avoid any aortocaval compression. Patient can be on diuretics and avoid volume overloading if the patient has ejection fraction which is less or is in heart failure. An infective endocarditis antibiotic prophylaxis is not routinely indicated in all patients, but those patients who have undergone surgical correction and have prosthetic valve placed prior to pregnancy need to be given an infective endocarditis antibiotic prophylaxis. So therefore, what are the goals of anesthetic management in these cases? We need to do a thorough preoperative cardiac evaluation so that we can stratify the maternal and fetal risk and optimize the patient prior to surgery. We need to prevent or treat factors that can cause decompensation and can lead to heart failure in these patients. Antibiotic prophylaxis need to be given. Anticoagulation, sometimes the patient may be on anticoagulation for thromboembolism prophylaxis. So we need to be mindful of that if we are planning on giving regional anesthesia. And we need to follow the appropriate ASRA guidelines for the same. Ensure adequate analgesia during the delivery and even postpartum. Hemodynamic monitoring, if required, we may need to go for invasive intraoperative and postoperative monitoring as well. We need to optimize the cardiovascular function as per the cardiac grid of the valvular heart disease. And we need to ensure that measures for resuscitation and postoperative intensive care are ready. So the factors that can worsen the heart disease that we need to avoid are anxiety, pain, any exercise, salt and water retention that can cause heart failure, treat anemia, treat any infection, any sustained dysarrhythmia that the patient can have, and any thromboembolism that can happen. So we need to ensure the patient is undergoing treatment or is undergoing prophylaxis for the same. The way we can stratify the risk for pregnant women who have cardiovascular disease is by using the modified WHO criteria. We understand the risk assessment is difficult and the severity can change during pregnancy also. So we need to have an ongoing assessment and have a tailored approach based on the baseline severity of valvular heart disease. According to AHA and ACC, there is ideally the patient with valvular heart disease should undergo preconception evaluation and counseling. However, sometimes they just present, as was the case here, the patient was unregistered. Therefore, we could not, the patient was not under any treatment prior to this. According to the European Society of Cardiology, we need to, it recommends an integrated risk stratification, which is known as the modified WHO criteria. What they have done is they have stratified the risk as per class 1, 2, 3, and 4 in increasing order of maternal risk. And based on the cardiac lesion, they have stratified accordingly. As you can see, most of the native or tissue valvular heart disease, which do not fall under class 1 or class 4, are actually class 2 to 3, which means the patient are at moderate to increased risk of maternal mortality or morbidity. The same thing is shown in this table. Here, I would like to point that as our patient is falling under class 2 to 3, the patient can have a cardiac event rate as high as 10 to 19%. And the patient is at increased risk of maternal mortality, almost intermediate level, and moderate to severe risk of morbidity. So we need to counsel the patient accordingly and ensure that we have taken high risk consent. We also need to know, here it is showing that the care during pregnancy needs to be a referral hospital. Ideally, a tertiary hospital will do where the patient has a cardiologist also to treat patient postpartum. Now, there are some risk factors that we need to be aware of and which we should be mindful of when we are evaluating these patients. They are maternal non-cardiac risk factors such as smoking or multiple gestation, and cardiac risk factors such as the presence of mechanical valve prosthesis, any anticoagulation therapy the patient is on, moderate to severe left-sided obstruction cases, and presence of cyanosis, and NYHA dyspnea class 2 or above should make us more vigilant in these cases. In valvular heart disease, high-risk indicators are those of WHO criteria class 4. These patients can have severe symptomatic AS or MS, any cardiomyopathy, low ejection fraction less than or equal to 30%, any Marfan syndrome with aortic root more than 45 millimeters, isomerization syndrome, pulmonary hypertension, or peripartum cardiomyopathy. These are all high-risk indicators in valvular heart disease, and we need to be very careful in these patients, as the most common complications in these patients are heart failure and postpartum hemorrhage. So as I said, the goals of anesthetic management were to stratify the risk. After that, we ensure the patient has, if the patient is on anticoagulation for thromboprophylaxis, we need to be mindful of regional anesthesia. Normally, the patients who have mechanical prostatic valve replacement done are on anticoagulation. Anticoagulant of choice is warfarin, which is a vitamin K antagonist. It is usually safe, but it can cause fetal embryopathy in the first trimester, so we need to be mindful. Normally, the patients are shifted to unfractionated heparin or low molecular weight heparin just prior to delivery. But there's a higher risk of thromboembolism with these cases, and they're difficult to titrate. Oral direct thrombin inhibitors like dabigatran and anti-10A drugs such as rivaroxaban and apixaban should be avoided in pregnancy. Regional anesthesia, if the patient is on anticoagulation, we need to follow ASRA guidelines because there's a high risk of spinal hematoma. Some patients who have a history of atrial fibrillation or prior history of thromboembolic episode, they should be put on low dose aspirin usually. Now, what is the mode of anesthesia for C-section? It usually depends on the hemodynamic status and obstetric indication. Preferably, we use regional anesthesia, as we did in this case, where we used combined low-dose spinal epidural anesthesia by giving 5 mg heavy bupivacaine spinal dose after securing the epidural catheter. General anesthesia can be given, but it's usually reserved for patients with severe AR with decreased ejection fraction with high chance of going into heart failure and hemodynamic instability. However, it is very important to note that there's no evidence to support any particular technique is superior or not, but cardiovascular stability is the goal, whichever technique you use. Now, what is the cardiac cause of aortic regurgitation in pregnancy? Aortic regurgitation occurs because of the failure of aortic leaflet coaptation. It can be due to defect in leaflet or aortic root. It can be because of congenital bicuspid valve. Most commonly in the developing countries, it's because of rheumatic heart disease. Some connective tissue disorders can be associated with it. There can be prostatic valve presence, such as mechanical or bioprostatic valve, and infective endocarditis can also be a cause of AR in pregnancy. Now, what is the basic pathophysiology of AR? Here, there is a decrease in cardiac output due to the regurgitation of a part of the ejected stroke volume. So basically, the patient suffers with decreased cardiac output state. Because of regurgitation, there is combined pressure and volume overload of the left ventricle. Now, how much of the regurgitation volume is, how much of the volume is coming back to the heart? It depends on the time that is available for the regurgitant flow to occur, which is determined by heart rate, and also the pressure gradient across the aortic valve, which is dependent on the systemic vascular resistance. So the magnitude of aortic regurgitation is decreased by tachycardia, that is by allowing less time for regurgitation flow to occur. And also if the SVR is decreased, then less regurgitant flow will occur and there is more forward flow. So therefore, the magnitude of AR is less with tachycardia and peripheral vasodilatation. As we can see that in pregnancy, there is, as we can see in pregnancy, there is already tachycardia and decreased systemic vascular resistance. That is why AR patients tolerated very well during pregnancy. There are certain 2D echo findings that we need to be aware of in severe AR. Mostly we calculate that by looking at the regurgitant volume. If it is more than 60 ml, it is severe AR. And if more than 55% of regurgitation fraction is coming back, then that is also indicative of severe AR. One second. Hello. Hello.
Thank you, Ritika ma'am.
No, a part of my presentation is still there. I think the screen sharing stopped on its own. I'll just get back to the screen sharing once.
Okay. Deepen will see any technical issues. 1 minute.
Yes. So is my slide visible?
Is it okay?
This is okay.
It's visible now.
Okay. Yes, sir. Okay. So the management of AR is based on this basic cardiac grid, which is which indicates how much the preload heart rate or contractility and SVR should be. In AR, preload should be normal, maintain normal or slightly higher because we want to maintain the cardiac output. Heart rate should be normal or even slightly higher. Like I said, tachycardia will decrease the regurgitate time for the flow to occur, and therefore tachycardia is required, but not excessive tachycardia. Contractility should be normal or higher as we want to maintain the cardiac output and stroke volume. And systemic vascular resistance should be on the low, should be decreased because the valve gradient is gradient will decrease and the forward flow will increase. So we need to ensure that there is a decreased SVR. Now, preload, like I said, it should be maintained normal or increased because aortic regurgitation normally decreases cardiac output and coronary blood flow. So preload should be maintained so that stroke volume is maintained and hence cardiac output is maintained. However, we can't overload the patient as there is very high risk of pulmonary edema and heart failure in these patients, especially those patients with have low ejection fraction and decreased diastolic function and systolic function in these patients. We need to give CVP guided fluid and strict input output charting need to be done. Adequate blood and blood products should be ready to be transfused in case of replacing the blood lost in cesarean section. If the patient is in volume overload, diuretics need to be administered. And we need to ensure the patient is in left lateral position or put a wedge on the right buttock to avoid IVC compression or aortocaval compression that can occur, that can lead to supine hypotension syndrome. Again, coming back to cardiac rate, the heart rate has to be normal or increased. Like I said, by maintaining a relatively high heart rate with normal sinus rhythm, it reduces the regurgitant fraction. It also ensures that cardiac output is maintained, as cardiac output is the product of heart rate into a stroke volume. However, excess tachycardia should be avoided because in these patients, during diastole, the coronary perfusion is decreased because of regurgitation. So we need to ensure that if there is excess tachycardia, then the coronary perfusion is decreased and the patient can have angina or myocardial infarction. So we need to be aware of that. Patient should be, to prevent any tachycardia, we need to treat any infection, anemia, ensure that there is adequate blood and blood product transfusion. We should avoid sudden hypotension because of sympathectomy or sudden sympathectomy in this patients. That is why we give low dose spinal with gradual epidural anesthesia. We need to ensure the patient has adequate analgesia, and we should also avoid bradycardia, as because of bradycardia, the regurgitation time will increase and the patient will have decreased cardiac output. Again, contractility has to be normal or maintained on the higher side to maintain cardiac output. It is important to note, even if the patient is chronic, moderate to severe aortic regurgitation, the patient usually tolerates well as long as the ejection fraction is preserved. Nevertheless, patients with severe aortic regurgitation are at very high risk of developing pulmonary edema due to heart failure. We need to minimize myocardial depression, which is usually occurring because of IV anesthetic agents. So we need to be mindful of that and maintain positive inotropic at all times. Systemic vascular resistance has to be decreased because it improves forward flow. Any increase in systemic vascular resistance can cause increase in regurgitant flow and decrease peripheral perfusion, leading to heart failure and pulmonary edema. So we need to treat preeclampsia and or hypertension vigorously. We should avoid sympathomimetics or vasoconstrictors. If G is given, we should need to avoid intubation and extubation responses. In aortic regurgitation, as I said, coronary flow is decreased during diastoles, and the reversal can occur even in severe AR. So we need to be mindful that we shouldn't decrease the BP too low. It should be maintained as up to 15% of the baseline is systolic blood pressure levels. Peripartum monitoring includes ECG, non-invasive IVP, pulse oximetry with capnogram and temperature, and input-output fluid monitoring as a minimum standard monitoring. However, invasive blood pressure may be needed in patients with WHO class 2 to 3 or patients with NYHA grade 2 above cases. Other monitoring methods that can be used are pulmonary artery pressure monitoring, pulmonary artery wedge pressure monitoring, or ABG analysis. Transesophageal echocardiography can be useful in patients who undergo deterioration intrapartum or may be posted for cardiac surgery alongside the section. However, we need to be mindful of certain complications in these cases. Most commonly, we see heart failure in these patients, and we should avoid and treat accordingly. Patient can go into pulmonary edema, can have myocardial infarction intraoperatively. Postpartum hemorrhage is common in these patients, and we need to know that oxytocin infusion is preferred over bolus because otherwise it causes precipitous hypotension. At the same time, ergometrin and carboprost should be avoided. Ergometrin because it causes vasoconstriction and can cause increase in SVR and afterload, because of which regurgitation can increase and can cause the patient to go into heart failure. And carbopros can cause further can cause risk of pulmonary edema, so that we should avoid it. Thromboembolism complications should be noted if it occurs. Complications related to prostatic valve, such as infective endocarditis or hemolysis, can occur. So we need to be mindful of that. So these are my references. Thank you.
Ma'am, on Narendra sir's topic.
Yes, now Narendra will speak. After that, at the end, she will put my slides.
Okay.
And will you
No
please
problem.
stop sharing your slides?
Okay, no problem.
Should I start?
Yes, Narendra sir, you can.
Am I audible to all?
Yes, you are audible.
Myself, Dr. Narendra Verma, working as an assistant professor in Department of Anesthesia and Ar Hospital. Today, I'm going to present a case of severe mitral regurgitation for lower segment cesarean section. Most of the things related to the pregnancy with the valvular heart disease are covered very well by Dr. Kritika in the depth. So I will not go into the normal physiological changes and the other things happen with the valvular heart disease in the pregnancy. So I will mostly stick to the mitral regurgitation only, and how we conduct these cases, even mitral regurgitation and other cases, by combining multiple mode of anesthesia in a single case for better outcome of the surgical skill. Metamorphosis of pregnancy takes a heavy toll on female mentally, physically, and emotionally. The plethora of the changes take place in female in all systems, but mainly on the heart and the vascular system. Presence of the heart disease, either congenital or acquired, preconception can further complicate the pregnancy. The normal heart disease that complicate the pregnancy range from 0.2 to 3%. The overlap of physiological changes of the pregnancy and the additional hemodynamic changes due to heart disease can affect both mother and fetus adversely. The better diagnostics tool and awareness have lead to the early detection and treatment of heart disease, better planning of pregnancy, and improved peripartum management of pregnancy with cardiac disease. Now, in short, we will discuss the mitral regurgitation in pregnancy. The cardiovascular changes associated with pregnancy and delivery induce the progressive stress on both mother and fetus. This change is well tolerated by a normal heart, but in the case of cardiac heart disease, there is a different picture. A multitude of changes occur in cardiovascular system during the pregnancy at the time of labor, as there is increase in the cardiac output with each contraction by 10 to 25%. It occurs because of with each contraction, there is auto transfusion of blood of around 300 to 500 ml. Healthy heart sustain these changes well, but not the diseased heart. Mitral regurgitation can go unnoticed during the pregnancy unless it is severe and symptomatic. The reason, because the regurgitation regions are well tolerated than stenotic lesion. Increase the blood volume and reduce vascular resistance, promote the forward cardiac output. So the regurgitation has the favorable scenario in pregnancy as compared to the stenotic lesion. The causes of mitral regurgitation may be the acute, either in the form of because of myocardial infarction or blunt chest trauma or rupture of chordae tendineae or papillary muscles and the infective carditis. And the chronic maybe because of rheumatic fever, then it mostly associated with the mitral regurgitation, connective tissue disorder. Most common being the mesometric degeneration, mitral valve prolapse. All these are the chronic causes. The acute EMR, the pathophysiology of the acute MR. In acute MR, left ventricle, there is a volume overload to the left ventricle. And so there is a increase in the stroke volume including both forward as well as regurgitator volumes. Because of, but there is a regurgitate volume, so there is a decrease in the forward stroke volume, so decrease in the cardiac output and the blood pressure. At the same time, the left atrium, because of the acute condition, it is not the compliant. So there is a volume pressure and overload that increases the sudden increase in the left atrial pressure. It may goes up to the 25 to 30 mm of Hg, which inhibit the proper drainage of the blood from lung to pulmonary veins and lead to acute pulmonary edema. In the chronic state, patient may have the compensated MR or may have the uncompensated MR. The compensated MR, forward stroke volume is well maintained, and there is a decrease in the pulmonary congestion, so the patient can tolerate the mitral regurgitation very well. But what happened in the uncompensated MR, there is increase in end diastolic and the systolic volume of the left ventricle, which increase the wall stress of the left ventricle. And gradually there is the left ventricular dysfunction because of the calcium deposit in the myocyte, which further decrease the stroke volume. And for decrease in the final output is there is a decrease in the ejection fraction over a period of time. And backward there is increase in the pulmonary congestion, lead to pulmonary hypertension, and patient may have the picture of congestive heart failure. Now I'm presenting the case which we have did by combining the different mode in the one case. The patient was a 33-year-old female gravid to parity 1 and live birth 1, 39 weeks of gestation in the labor of postage for urgent lower segment Cesarean section in view of non-progression of the labor. Patient was admitted with a complaint of abdominal pain and per vaginal discharge since 5 hours. Patient was not a registered case at our hospital, but on the further history taking, patient gave the history of frequent dyspnea on the exertion, NIA class 2, and the being diagnosed as a case of mitral regurgitation since 4 years. But patient was on diuretic tablet, furosemide 20 mg TDS and metoprolol 12.5 mg OD since diagnosis, but she was on irregular treatment and stopped since post-conception. In the obstetric history, there was emergencies previous LACS 7 years ago in view of fetal distress that go done under the regional and uneventful. There is no other operative history. There is no allergic or adduction history. On examination, patient was averagely built of febrile, pulse was around 80 beats per minute, present in all peripheral pulsation. BP was 100 to 160 mm of Hg. Pallor was present and the bilateral pitting edema was present. No other significant finding on the general examination. On systemic examination, patient was conscious, oriented, little bit restless with bilateral, occasional fine basal crepitation was present. We rule out the basal crepitation by asking the patient to take deep breaths and the coughing, but still that present, so we conclude that it is a basal crepitations are present. Then the cardiovascular system, apex base shifted to left and fourth intercostal space. On auscultation, there was a hollow systolic murmur was heard over the mitral area and radiating to the axilla. On investigation, hemoglobin was 10.9 and the rest of the LFT, RFT platelet was within the normal limit. ECG shows the sinus rhythm and the sign of LVH, prominent RV in the lateral chest and left exit deviation and left atrial dilatation that is detected by the BiPIC P wave. 2D echocardiography report was available showing finding of thickened film mitral leaflet. LA was dilated, left ventricular hypertrophy and dilated. Regurgitation in the form of percentage of left atrium was around 50% and regurgitational volume was around 55 ml per beats on the Doppler. So we concluded it is moderate to severe MR. Ejection fraction was also slightly decreased, that is 45 to 50, and there was also a moderate pulmonary hypertension. We did the ABG. ABG shows the pH was 7.3, saturation was 95 to 94, and PO2 was around 90 mm of Hg. Prior to procedure, blood grouping and cross matching was done. And anesthetic consideration and the goal for the MR pressure in the pregnancies, prevent the sudden increase in the systemic vascular resistance, as increase in the systemic vascular can increase the regurgitation fraction and decrease the cardiac output. Try to maintain the sinus rhythm, maintain heart rate at normal or slightly increased rate. Aggressive treatment of atrial fibrillation if present, and optimize the forward flow by adequate left ventricular preload, but also avoid the excessive fluid administration as it take further push the leaflet away and increase the regurgitation fraction, and so that can also lead to a right ventricular failure. Avoid the O2 compression to maintain the preload, and prevent increase in the pulmonary arterial pressure by avoiding hypoxia, hypercarbia, hypothermia, acidosis, and mild hyperventilation is accepted. Avoid myocardial depression from the general anesthetic. Case management. The case management of sub patient in the pregnancy is multidisciplinary team approach by discussing with the cardiologist and the obstetrician. Patient was taken up for the LACs after explaining the anesthetic procedure and the associated risk and taking the written and informed consent. All routine monitors or attached pulse oximetry, ECG, CAPNO, NIBP temperature were noted prior to the anesthesia induction. Before inducing, the patient took the right radial, right arterial line and the right central venous cannulation after local and the IMLA application. Preparation of such patient in the OT involve the preparation, make the infusion pump ready with the inodilator. We usually use here the dobutamine, defibrillator, vasopressor if required, the norepinephrine and diuretics. The aim of conducting such cases is maintaining hemodynamic stability and the safe execution of surgical procedure. The plan of anesthesia for this patient and other, even including the stenotic lesions, we combine the different mode of anesthesia like intravenous analgesia, intrathecal opioid, abdominal wall blocks, and endotracheal intubation. Before inducing the patient, we use the 10 mg Lasix in your fluid overload and pulmonary finding. Intravenous analgesia was given by injecting the by IV paracetamol 1 gram, combining all these drugs in 100 ml of normal saline, 1 gram paracetamol, tramadol 25 mg, Hylocort 1 to 1.5 mg per kg, and it is infused over the 15 to 20 minutes along with the injection data intravenously. It is not mixed in the same point. The purpose of this is not new, and this is not this intravenous analgesia cocktail is not new, but we combine the different mode in the same patient. Just the aim just to avoid the stress response to this valvular heart patient because of stress of general anesthesia like laryngoscopic and intubation, as well as the surgical stress. After that, under all aseptic precaution, we inject the fentanyl 25 mics, half cc. After mixing it with the CSF and making the volume up to 0.8 ml, and the sensory level was at around 8 T8 to T10. Fentanyl intrathecally is comparatively hypobaric, but after mixing to the CSF, it is like isobaric. It acts like isobaric. After intrathecal fentanyl, we make patient supine, and then we induce the patient by rapid sequence induction. The inducing agent used is etomidate. Is total dose given is 13 mg, and succinylcholine, and relax with the succinylcholine 75 mg with the required pressure. And all the time we keep the wedge under the right hip. Laryngoscopy was done. Airway was secured endotracheal number 7 and put on the mechanical ventilation. And patient maintain on the oxygen, air, and sevoflurane. MAC, try to keep the MAC at titrate to 0.8 to 0.6, and with the intermittent bolus of rocuronium is given. After that, we give the blind landmark guided bilateral transverse abdominal spleen block using 0.2% ropivacaine 30 ml, 15 ml on the each side. The whole purpose of combining all these modalities just to avoid the stress response to the patient, maybe because of GA or surgical stress, and avoiding land up into the complication of the valvular heart disease. That's like pulmonary edema, cardiac failure, and we conduct 8 to 10 such cases. By combining all these approach will go very well, including the moderate to severe stenotic lesion also. Post-delivery oxytocin was administered by 3-unit bolus and then the remaining 20 unit per hour in the normal NS. Throughout the procedure, 300 to 400 ml of crystalloid was given and patient kept warm throughout the procedure. Fetal Apgar score was also good at 0, 1 and 5 minutes was good. Patient was reversed as top count of 7 and extubated on OT table. Patient then kept into post-anesthetic care unit and shifted to OR after 24 hours. There are many, there is US FDA not approved the IV tramadol for during the pregnancy and the lactation, but the dose of tramadol we use is the 25 mg and many other people use it in the same dose. At this there is no much side effect to the maternal as well as fetal. There is no fetal bradycardia. We not find in any case there is any fetal bradycardia or anything else. Even the intrathecal fentanyl, it is a hypobaric, but by diluting with the CSF, it is come to be the seems to be the more isobaric. So there is a the only issue with the segmental analgesia and the patchy effect with the fentanyl. So for better pain control, we combine all this with the tab block just for the analgesia purpose, and GA only to make patient unconscious and the relax. In conclusion, the physiological adaptation of pregnancy overlap with the pathology of regurgitated wall may pose a challenge during the gestation and peripartum period. Vigilant monitoring, early detection of the disease, and its severity assessment help in reducing a plan for smooth and complication-free conduct of labor and delivery. Combination of both general or regional or combined in regional or general or with the blocks, you can done the case, but just we have to maintain the hemodynamic stability and keep the preparation of anticipated complication that can occur in such a valvular lesion. Mitral regurgitation, mitral stenosis, moderate AS, and the AR can do either in the general or neuraxial block. Just we have to maintain the hemodynamic stability, or we can combine all this in the same patient to prevent the complication of valvular, because most of the time plain general anesthesia land up with the complication of valvular and patient get the pulmonary edema or failure, and most of the time it causes the fetal mortality, and the GA drug has a depression effect on fetus also. Thank you.
Thank you, Narendra sir. I think it's our stalwart ma'am will speak after this. Before that, I want to share to audience that this is the second meet that ma'am is presenting with their whole team. Before that, we presented that cath lab was presented by ma'am, and this one is on ops. It's very much question and answer will happen, but before that we will share key points from Lipika ma'am. Ma'am, please.
Okay, thank you, Dr. Sachin. I'll just ask Kirtika to share the slides.
Yes, ma'am. Sharing the slides. Is it visible?
Yeah, the current burning issue, actually it is all told by Dr. Ashish, Dr. Narendra, and Kirtika in perspective to a cardiac regurgitant lesion, because you all had discussed about the stenotic lesions before, like mitral stenosis, aortic stenosis. So we picked up these cases, but in general, in obstetric practice, what we are going to follow and what the recent literature is saying or guiding us. Next, Kirtika. Yeah, coming to the obstetric emergencies, they always pose a challenge to both us, the anesthesiologist and obstetrician, because it has high maternal and neonatal morbidity and mortality. Next. Next. Yeah. Based on the urgency to conduct the cesarean section, actually, they are always categorized as elective and emergency, but not all non-elective cases are emergencies. In emergency surgery, there is a terminology used which is called as DDI as per the 2004 NICE guidelines. They have divided it into urgent and planned emergencies. They have divided into category 1, category 2, and 3. Category 1 is the one where we get only 5 to 10 minutes available in minutes. And by that time, the baby delivery has to be done. That Dr. Ashish discussed before, which are the conditions. They are given here in the left side. And here, till now, the technique of choice is general anesthesia only, or we can go for the rapid spinal anesthesia also. That I'll explain how we make the spinal rapid. If we know that the baby delivery time, that is category 2, 10 to 15 minutes are permitted for the baby delivery time, then we can go for spinal anesthesia, and still general anesthesia can be given pertaining to the patient's medical conditions and other conditions. And if it is elective, then more than 20 minutes, then we can just give the top up in the existing epidural, or we can add spinal anesthesia, and if the patient's condition demands, then we go for general anesthesia. Next.
Yes, ma'am.
Coming to the decision to delivery, which one? The target decision to delivery interval, which is known as DDI, actually is actually here the GA is supposed to have a very high mortality and morbidity, and this still warrants the technique of general anesthesia. This I discussed already. Next.
Yes,
Kritika,
ma'am. Yes.
Yeah, coming to the pre-op assessment of these patients. Here we have to do a very rapid anesthesia assessment. Here we have to, it's a must, even though we are giving spinal, we have to assess the patient for risk of difficult airway, risk of obstetric hemorrhage. Like here we have to take consideration of all these placental conditions and the risk of aspiration. And pre-op investigations, we keep it to minimum, like complete blood count, blood grouping and cross-matching, RFT, LFT, and coagulation profile when it is needed. Here, I would like to say that while we are assessing the patient for obstetric hemorrhage, like placenta, abruptio placentae or placenta accreta is there, there we have to have the coagulation profile INR done, because preoperatively they are sent to the radiological unit to embolize the patient, like through uterine artery. They put this in they embolize, and they keep the balloon put there in the previous day, which is placed in the up to the internal so that the bleeding is less when the section is being done next day. In KEM, it is a very routine practice, like many cases they have been doing. And there we need the coagulation profile, a proper INR done. Otherwise, in other cases where we have patients who are coming with prosthesis, heart valve, then in those cases, or they are on particular drugs, in those cases only we need it. Otherwise, we are going to ask for all these investigations for a normal cesarean section patient. Next. Yeah, then here it is a new, all patients coming for two sections, as I told you, has to be prepared for GA, and hemorrhage preventive measures are to be taken. Here, a terminology is being used to improve the better outcome of the neonate, that is called in utero resuscitation of the fetus, where it is mandatory to maintain the position. Left lateral uterine position is to be maintained. Oxygenation has to be done. the mother, and intravenous crystalloids adequate has to be given so that hypotension is prevented, and a target blood pressure is maintained, like to maintain the perfusion, to maintain the uterine perfusion, and very low tolerance for hypotension. And tocolysis has to be done, like with Turbute 250 microgram subcutaneous or GTN 400 microgram meter dose aerosol doses. And here, of course, acid aspiration prophylaxis is a must, as we know that they are very much prone for aspiration due to the pregnancy conditions, the changes. And difficult airway preparation always mandatory part of the preparation while providing spinal anesthesia also. And intravenous access securing is a must. And invasive monitoring, if time permits, in cardiac patients having cardiac lesions, which are grade 3. Next. So coming to the anesthesia for category 1 cesarean section, of course, here, as I told you, it is the rapid sequence induction of GA is the mode of choice of anesthesia, and rapid delivery of fetus is the goal. Next. So here maternal assessment and stabilization from time to time decision has to be taken, like about the maternal condition, and the fetal monitoring also plays a big role here. And IV induction agents regarding that, yeah, of course, pre-oxygenation is a must here. It is practiced. Tidal volume breath is given for 3 minutes, or 4 to 8 vital capacity breath is given. And IV induction agents about this thiopenton 5 milligram per kg along with succinylcholine is still the preferred method, and it is still coming in the literature for Indian population. And of course, rocuronium sugammadex is going to replace it soon if it is available and it turns out to be economical. And otherwise, ketamine and etomidate might help us for treating such kind of patients, but propofol is not to be preferred in these obstetric population because it is associated with a worse neonatal profile. Neonatal outcome is not so good if you compare with other inhalational agents. And cricoid pressure we start giving from the time of just when we start inducing the patient from 10 Newton towards the loss of consciousness up to 30 Newtons we can increase. And regarding the opioids, fentanyl up to 25 mics are okay. And Sufent we can use, of course, remifentanil, but still morphine has a place. But that interferes with the Apgar score definitely. Morphine and other norphine, still it is a practice in adding into spinal anesthesia, sensor cane and using it. But then we have to be very careful about the neonatal aspect of it, and the pediatrician is to be informed about it. And if there is a difficulty in intubating the patient, then second generation supra-airway devices have a role. And coming to the perioperative care, the minimum monitoring standards along with EtCO2 monitoring is must. Then extubation is another stressful condition while giving general anesthesia to this group of patients because they are more prone for hypertension depending on what they have gone through. And that is also becoming a critical event in the course of general anesthesia. Next. So coming to the this rapid sequence spinal anesthesia, here if the epidural catheter is already in place for providing labor analgesia, then a top-up can be given, but it is always to be confirmed that the epidural catheter is in place. And here the skilled anesthesiologist has to give the spinal anesthesia because here the timing is a factor and the block has to be successful. Here we have to limit the number of attempts. And if the spinal action is delayed, then there has to be very low threshold for providing general anesthesia. And of course, 0.5% BPVAC in heavy and 0.75% ropivacaine are used, no touch technique. And immediately the surgery has to be started once T10 sensory level is reached. Next. Next. Next one, Kritika. Go to next. Yeah. Here we use spinal or epidural anesthesia as the technique of choice. And here the GA is not so much preferred in these category of patients due to high risk of complications of GA. Next. Next, Kritika. Please go to the next one, Kritika. Yeah, coming to the complications of emergency C-section. Here, I would like to emphasize more on these two kind of complications because we get stuck usually due to these complications because providing anesthesia and spinal anesthesia, we all train our trainees very well and they become adept in providing that. But when these complications occur, like first I'll discuss about the anesthetic complication, like failed intubation or aspiration or failed neuroaxial block. Previous one, yeah.
Yes, sir.
Then suppose we are with the anesthetic complications, then there we have to have our first thing is we have to take very fast judgment regarding failed intubation, and we have to realize that pulmonary aspiration has taken place. And if it is a failed neuroaxial block, then we should have very low threshold for converting into general anesthesia and realizing the complications of hypotension and or delayed action of the spinal anesthesia or any other problems, because inadequate anesthesia and analgesia also gives rise to other complications at this point. And of course, we have to recognize the allergic reactions, like in terms of anaphylaxis, or it can be LA anaphylaxis, or it can be to any agent which is being used. And awareness during anesthesia, obstetric awareness is a very big factor. It is very traumatic. And of course, extensive spinal anesthesia or high spinal block has to be recognized and to be treated. Coming to the surgical complications, like hemorrhage is the biggest killer in this category of patients. So as I told you, if preoperatively we know that the placenta accreta or all these placental conditions are involved, then we can take the radiologist's help. Then we need a good communication and decision making with obstetricians so that the balloon can be put in place. So that at least the loss of 5 liters can be reduced to 2 liters, and the hemorrhage, it makes a big difference in the patient's management. And of course, thromboembolism is, as soon as it happens, it has to be detected and treated immediately. It can be amniotic fluid embolism, it can be DVT, and it can be any other embolization which can happen. So these two things, they can happen anytime, and we have to maintain constant vigilance for that. And of course, if the surgeon is doing delayed extraction, then there is risk to the fetus. And amniotic fluid embolism can happen by the time they deliver the child and the placenta is getting delivered. And maternal collapse, we know that various causes, and maternal collapse causes and management is a must for us when we attend to obstetric category of patients. Next. Coming to the 3 most common causes of maternal mortality and brain injury, it is failed intubation, it is high neuralgia anesthesia or high spinal, and thromboembolism. Next. So coming to the management of failed intubation, obstetric airway is always, anytime, even though we have given the spinal anesthesia, it is an anticipated difficult intubation all the time throughout till the baby is delivered and the case is finished. And suppose we are not being able to intubate the patient, then change of hands, a change of equipment. And now it is said that video laryngoscopes can be very useful. And supraglottic airway device can be kept as a plan B. Through that, if the flexible bronchoscope is put, then that can also help. Then maintain the oxygenation. That is the biggest priority, but it is seen that unfortunately high frequency nasal oxygen, which is being used in other category of patients, have helped so much. They worsen the saturation. The SpO2 values don't come up in pregnant patient, unfortunately, so they don't help. And front of neck access in CVCO scenario, pre-procedural USG can assist. And anytime pulmonary aspiration has happened, even under spinal anesthesia, it has to be detected because it can worsen the situation even more, even in GA, in failed intubation, or in spinal. Next. Coming to massive obstetric hemorrhage, which is a major cause of mortality again. Here, we would like to know that transfusion trigger is usually 7, HP of 7. In the face of bleeding or constant bleeding, like that is changing this, because if it is uncontrolled hemorrhage which is going on, then we have to anticipate and we have to procure blood and we have to give it blood products. So that is for that we have to take the experience of the seniors, and we have to take a really immediate stand, and we have to make the blood available, because we have lost patients due to providing them blood later on. When they needed, they could not receive the blood. So when the anaerobic metabolism sets in, then if we transfuse, it's not going to help the patient. So the decision has to be made earlier and faster. And regarding the antifibrinolytic, like Tranexa 1 gram IV within the Cesarean section is a must. Like there is a very positive feedback by the women trial. That is a big multi-hospital, multi-country trial where they advocate that 1 gram IV Tranexa should be given within 3 hours of Cesarean section procedure. Not in vaginal delivery, but in Cesarean section. And that really brings down the bleeding a lot. Then the fibrinogen level in the face of PPH is 100% predictive of outcomes. Like if the fibrinogen level is falling, if it is less than 2 gram per deciliter, then we have to replace with cryoprecipitated fibrinogen. And if there is more than 5 liters of loss, then also we have to give cryo and fibrinogen. And placental abruption, as I told you before, like in case of if it is known like placenta accreta spectrum, any patient is lying on that, we have to take interventional radiology consultation and intervention, and we have to give them immediately blood products along with platelets and cryoprecipitates. And of course, viscoelastic POC test guides the transfusion wherever it is available. Next. Coming to the other crisis which we face in these obstetric group, like when they have this PET or preeclamptic traits, that is hypertensive crisis. So there usually the systolic BP is more than or equal to 160 millimeter mercury, and diastolic is more than equal to 110 on 2 separate occasions, at least 4 hours apart. And here all these they positively they have the adverse cerebral events, which is very real. So we should be always trying to prevent it by using esmolol or labetalol, and proper antihypertensive drugs are to be given. Then it has to be detected, and of course, if the PIH component is there, then Magself has to be given. The regime has to be maintained throughout. So this also gives rise to the unwanted crisis, which the anesthetist only has to manage perioperatively. Next. So to conclude, the emergencies in obstetric practice poses a unique challenge to the obstetric anesthesiologist. Even though they are rare, high stake and high dynamic events with potential for rapid deterioration of both mother and the fetus are there, and multidisciplinary teamwork is needed. And we are actually the peripartum physicians who have to take care of 2 lives. And training and simulation in obstetric emergency scenarios can really improve the outcome with obstetric anesthesiologist playing the central role. So we must prime ourselves for training and learning the decision making in the face of changing scenario. Thank you.
Thank you, ma'am. Very elaborative thought. You cover almost everything on Obesio. And we, as an anesthetist, run at any time when sections fall come. So a lot of questions will come today. First of all, I want to share one thing that what effects on CVPS cases like aortic regurgitation and mitral regurgitation cases, pitocin and methargine effects mainly. So, ma'am, thank you, ma'am. How to handle these 2 drugs, pitocin and methargine in cardiac compromised patients, basically.
Methargine is to be avoided, but oxytocin initially the small bolus initially up to 5, and then later on because see the uterus has to contract also well, so it's okay to avoid methargine, but carboprost like it can to permanent. If it is given graded dose, then it is okay.
Hello.
Yes, sir. Yes, sir. Yes, sir.
Yeah, the basic what we can do the best is we should give initially a bolus of about 3 to 5 of pitocin, and then pitocin is given in the infusion as a new norm. That is 20 units of pitocin should be diluted till 20 cc and given over 5 ml per hour, so that there is no breakthrough contraction. Sometimes what happens, the uterus contracts, then it again becomes relaxed. So it has to be given in an infusion rather than in a full bolus. Methargine is definitely to be avoided and carboprost has to be taken with care. These are some of the new norms which are followed. And a new drug which has came instead of pitocin, that is a carbitocin.
Yes,
that is a new drug. So that was the coming recent trend regarding that, which will avoid.
Yes, sir. So how about carbotoxin? What is your experience on that?
Carboprosin is very dangerous for cardiac patients, especially when considered to be coronaries and also for lungs. It is better to be avoided. Even some gynecologists prefer to give carboprost in the uterine directly. I think you must be quite aware of this. But this is a quite dangerous procedure because we might just land up the patient with a coronary events. So better the more important practice is to be avoided in something like asthmatic patient. Other things is you don't have to give the full dose. You can give half dose or 1/4 dose. And basically pitocin is given as a basic drug and carbopitocin SOS if required. Better to be avoided. Just try to give 1/4 of half drug. IM, that also after aspiration for the blood.
Okay, sir. Newer drug is coming instead of pitocin. Many of gynecologists asking for carboxytocin. One drug new coming. Yes, carboxytocin. And that drug related to CVTS cases or any regurgitation cases.
That is, which is not given to be an infusion, but the bolus has to be given around about 10 to 12 minutes, 12 to 15 minutes. But I have not used it. I just used it once outside. But as per the reports, it is supposed to be very, very stable and causes minimum of the hypotension. And it basically, once the uterus starts contracting, it doesn't go out of that. The problem which we face with pitocin. Similarly, what they tell is it doesn't cause much of a water retention, as it is caused by pitocin. So it is much healthier.
So we can safely give carboxytocin.
Yes.
It will
Currently,
be,
KM is
yes.
using a lot of carbitocin, so I think we can use this new drug. And we use lots of fluid for giving pitocin also, because
Yes.
in norms we generally pass a 500 ml a DNS or 5% or NS and put
Yes.
20 units. So that adds to the fluids of the patient plus the auto transfusion which comes. So it causes edema, more chances.
So it will be from stalwarts institute and stalwarts speakers. We can use carboxytocin easily on
Yeah, definitely.
yes, cardiac compromised patients easily. So on normal patient you can use easily.
Definitely. Start using on normal, then we can come on the hard. That's better when it's
Yeah. So that was the really we need to hear from you. Basically, it's a under trial drug for a private forum point of view. So we are
private typically, but start because KM
really
I started using. My wife is in KM, so she uses it regularly. It is giving good
okay.
results. So that's why I'm telling you. Nair
So
garu
sir has mentioned especially for us that her wife is anesthetist and
No,
she is
she's a
using
gynaec.
regular. Okay.
She's a gynaec, so I handle both things.
Okay.
I have to take care of the uterine contraction of her also, so that's better.
Okay. Sir. So one thing I want to ask from cardiac point of view, Kritika mentioned in one slide that we need a CVTS clearance for that case of CVT, Cesarean section in, I think aortic regurgitation, like that. Our private forum point of view, we are very much scarcity of CVTS surgeons. Basically, we have cardiac person, but not CVTS. And in that case, how can we recognize that? I should.
Basically, we don't want clearance as such. We just want an opinion of an expert person. So something like CVTS or cardiology, just regarding the management of tachycardia and hypotension. Basically, it becomes a medico-legal issue rather than what is required, because they cannot come directly for intervention. But basically, what has to be done, because they are more expert and they handle these cases in and out. So they have a better hand of that.
Actually, in where there is a valve replacement done already, in those cases,
yes, ma'am.
It's more relevant, because the patient is already on warfarin and already a prosthetic valve is already in place. So there, for a choked valve scenario has happened. Like already the patient has been, if the warfarin and all these INR and everything is not maintained, the land valve scenario post procedure, post section, it has happened. So that has to be taken care of.
So overall, I think so that CVTS point of view, one hand raise was from Somaya ma'am. I think so. Ma'am, you can unmute yourself and can ask question. Till then, I want to ask about one question from Narendra sir's case, that he mentioned about fentanyl in intrathecally, and then he mentioned about GA for relaxation and stabilization of CVS system. So, sir, is it okay to give intrathecal fentanyl or what I can say levoanavine or ropivacaine drugs?
Yes, sir. We can find the ropivacaine or bupivacaine in the low dose. 2.5 mg of bupivacaine is also enough, but we just try to avoid the local anesthetic, and we are trying to use just the pure opioid for better hemodynamic stability. Combination also good. There is also fluctuation in hemodynamic in the low. That time no need to do a barbiturate, and the volume is also approximately 1 ml. It is also even fentanyl for if you are trying, you can use the intrathecally for amputation or initial use. You can find the there is some segmental acid loss, anesthesia
Hello.
So
अरे
there is no
येतोय
sole
तर क्वेश्चन आन्सर
antithesis.
चालू
It
आहे.
will help you by using other
तुम्ही
multiple.
निघताय का? नाही ग.
Hello. Hello. Hello.
Yes, we can hear.
Anything else, sir?
Sachin, we can't hear you.
Now I can hear.
Yes.
Maybe
yes,
I'm
now.
I'm audio. Yeah. So Narendra,
Yes, sir.
I'm what I want to say is we are the private forum point of view. I am asking this question that you use in your case regional
Yes, sir.
fentanyl. Yeah, with that you use the GA for that
Yes.
case.
Yes, sir.
For you mentioned that you use GA for a reason of relaxation point of view and cardiovascular stability point of view.
Relaxation point of view, yes, sir.
Yeah. But even in nowadays, people are really using segmental spinal or low dose of spinal cases.
Yes, sir.
Yeah. From that point of view, you can share your thoughts with our viewers so that they can easily do these cases in a private point of view.
Our segmental spinal is about 1.5 to 2 ml, but in the section, the segment, because of that hypobaricity and the position is very difficult to predict the spread and to cover, because we have to cover at least T4. Otherwise, we can give the segmental spinal, but in the valvular or cardiac patient, severe patient, we generally avoid the spinal altogether.
So only use fentanyl.
Yes,
That was
the low dose of bupivacaine or ropivacaine is also good, sir. Is also good option.
okay. Thank you, Narendra.
Just to maintain the hemodynamic stability. That's all.
Yes. From Somaya and Java, I think Jaya has raised. They both raise hands. If any question from Somaya, can you ask, please? Unmute yourself and can ask.
No, sir, I don't have any questions.
Jaya, you raise hand. I think you have any question, please ask. I think Jaya also don't have any question. So overall, ma'am, we know as an anesthetist related to both drugs that carbotoxin new drug is coming in our private forum point of view, and CVTS cases. Generally, we don't have cardiothoracic surgeons at our places. One question on that only, that in which cases we really need CVTS opinion for going for seizure.
Yeah, as I told you, like whenever they are coming with with bioprosthesis valve or mechanical valve, in those cases we require
Yeah.
previously and after the procedure, because suppose they bleed and some blood products or some plasma FFP are given. or sometimes
Okay.
the gynecologists they stop altogether the any kind of, usually they are on warfarin, they altogether they stop it only. So then they land up in the postpartum period, they land up
Yes.
in the choked valve scenario. That is like life threatening, like it becomes an emergency, absolute emergency. So at least whoever is there, like, 2 hours, 1 hour vicinity also, you can just contact the center. So at least if they do the TD or something, they can make out the valve functioning, and because they become breathless post-operatively, they become breathless, which is mismatched to their clinical scenario. Like it's not related to the section condition. It is because of their deterioration, valvular-wise. The valve stop functioning.
Okay. So, guys, only wherever patient came to us that
Yeah.
wall replacement cases or maybe related to
Or
wall.
yeah, or if they're very badly regurgitant lesions, like beyond grade 4 or so, where they can't lie down, because the regurgitant lesions, they behave very badly, like in face of bleeding, or when they get used to it, they don't take it very well, like their HBR and all these things. If it changes, if the pain relief is not taken care, or they have got a while delivering all these drugs and fluids, a lot of interplay, all these can happen. Then they can have sudden pulmonary edema. They can have, usually they go into pulmonary edema and they become dyspneic and low output
Okay.
spread very fast. So,
So that
so
time we need.
after the baby is delivered, then they can at least go for a follow-up for their
Okay.
condition. Sometimes it worsens.
Okay.
Yeah.
So thank you, ma'am. On this note, basically we are related to worry about cardiac output mainly, and that thing was really cleared mentioned by Kritika Yadav, Narendra Verma sir and Ashish Mali sir, and on top of cherry, Lipika ma'am really clear cut mentioned about that thing. Even about pitocin methargine, they mentioned really good on that thing. Ma'am, uh, whatever we learn in our practices, that we go for distressed patients very fastly, that call come from OBGYN person and they, that there is a distress
Lot
and
of
we go for
medical
that.
legal aspect also to that later on
Yes.
nowadays.
Yeah. So really medical legal point of view also you have to worry on that thing also, that you cannot even go for any cesarean section in distress. Medical legally it's safe that you are saving a child and mother for that cases, and this is life-saving procedure we are going for day and night. But overall, sometime we miss these procedures, CVTS point, almost cardiac point of view. Actually, even respiratory point of view, you can manage on table also. But a CVS point of view, really, it's a very difficult to manage without any other colleague also, because sometimes cardiac failure is really worrisome thing. That one case happened at Rajasthan, that gynecologist was expired. But really, myopathy post-op PNC patients in intra cardiac myopathy is happen. So really, use drugs very judicially. What
Yes, that is very important. Yeah. And
Yes,
this
yes, yes.
technique is really good, which you described, like giving only fentanyl without adding any
Yes,
other
yes, yes.
sensor chain or anything along with GF. It's very stable and very, you are in control. Like,
Yes.
yeah.
So I'm on our society point of view, I'm appeal to all our members that we are very much fortunate that this case meet is happening with Lipika ma'am, and all our queries almost, I think so, no question from any audience. Everyone was satisfied with this case meets.
Okay, thank you, Sachin, for
Sachin sir.
giving us opportunity. Yeah.
Hello,
Ma'am.
Sachin.
Yes, sir.
Yeah, just one last note that the gold standard of clinical things still remains with the stethoscope and clinical evaluation on the patient.
Really,
Which your
really,
main
really.
query was there. The gold standard
Really,
still
really.
remains the sthetho. The most work of the anesthetist is just put a sthetho on the chest to see the chest, that is the lungs, as well as the lung for the heart for any murmur. That is still the gold standard. That will save
Really, sir.
50% of you, and the good communication skills with the patient as well as the relative. That will solve,
Really,
I think,
really.
70%, 75% of the problems and take care.
Sir, I work in municipal corporation. Actually, I want to share one with you
Yes,
also
yes.
and ma'am also. Actually, I'm working in municipal corporation at Nanded. Out of OT, I mentioned one note: mehndi or nail polish, whatever it is, on. I will not allow that patient in OT
Good.
because that SpO2 is maintaining was my aim to that cases. So I never allowed these patients, first of all. Then other things is very far related to CVTS and even thyroid cases and all. Most of the time, even mizolam we gave and patient went into apnea. That
Yes,
can
yes.
happen. Yeah. So really, we should really serious about these things and judiciously use your drugs.
Yes.
What madam mentioned in this. So this I think flame. I say flame is going on all over India
Yes, yes,
and
yes.
state.
Exciting.
Definitely.
Yeah, we are discussing on OBGY. That was both things are really. It's post Navratri. We are
Yes, yes.
these things are happening, but overall, I will thank you to Lipika ma'am because she was the lady. He actually when I ask him that one topic or one question, she clearly mentioned, I will take 2 case meets, nothing to worry, and that happened today. I'm really thank you to Narendra Kumar, Ashish Mali sir, even Rameshwar, our junior, also Kritika Yadav, and Lipika ma'am. I'm hats off to you that whenever any question or anything, I'm ready for you. I think Varsha ma'am
Yes.
mentioned Supam
Super.
madam. Yeah, my family is always great, and because of that, I'm doing this thing. Really, and next time, Indrayani ma'am is coming on our platform, and then Dave ma'am is also coming on our platform. With that, one private forum person, Raju Tushar Chokis sir, he is coming on our platform. Opioid free anesthesia and TIVA. He will make the scene for private forum. I'm actually lost my academic touch when I pass out from Nair, but now I'm coming to academic point of view. Basically, I want to share our all private forum person that they can watch these videos in when they are free time, and when maybe sometime people are coming very less in our academic meets, but our mention is that everybody should touch with academic, and one data is there in from US point of view. US academician mentioned in their any one case meets or conference, something like that. They mentioned that burnout of private forum practitioner or doctors is due to less academic touch with or less academic touch. So we are in touch with academics, then less burnout of in your private practice. So I am doing these things too. Daily academic touch will really help you in your day-to-day practices. So thank you all of you from ISA Nanded, especially ma'am. I'm really thankful you.
Thank you all. It was nice.
Thank you all.
Good night.